And now part 2 of this 2-part video. Part 1 showed the timeline from June to September 2015, including blogs and emails. It also included some of Dr. Kirkpatrick's assessment videos and a look at a functional neurological disorder, as well as complex regional pain syndrome. Part 2 begins with Dr. Kirkpatrick's assessment of Maya, available on his public YouTube channel, first showing this photo she posted on her blog. And now the video from September 2015.
As is found in many pediatric patients, the inciting injury that triggered the CRPS is difficult to identify. The patient was becoming progressively more incapacitated. The patient had many comorbidities which would complicate her treatment, such as asthma and with possible immunodeficiency. Pre-evaluation.
So let's go over your history just a little bit, okay? Approximately 3 months ago, you started having some pain down in your feet here, okay? Here's what's important to understand is that there is no particular injury we can attribute this to, okay? Also, another thing that's important to note is that with that, she notes different fluctuating temperatures between the two sides. In other words, sometimes one side would be colder, sometimes one side would be warmer. And sometimes one would be more red than the other, but it would flip-flop back and forth, okay?
Or purple.
Yeah, or purple, right. So this is typically what we see with RST. But she has some other features that suggest that this is just nerve pain, that it's more RST. The fact that it did tend to spread. It started down there, and then she started getting some tingling in her upper extremity, but that seems to be improving in recent times. Is that right? Yeah, right. And also, you see how her legs are turning in. That's typical of what we see with the RST. We call that dystonia, okay? Dystonia. In fact, it's so bad right now, she can't even bear weight safely by herself. It won't happen. It won't happen, okay? And she also has this thing that's characteristic. She has the allodynia. We're going to talk more about that in a little bit here, but that's why we marked her down here in her leg there, is because she's got that. As she goes down, it starts to feel like road burn, right? Maya. Did I finally say it right?
Yeah.
Did I say it really right?
Yeah,
okay.
Doing so much better.
Okay, you ready for some testing?
Yeah.
Okay, 2 vertical fingers in your mouth. Atta girl. Good job. Are you having any pain when you do that? Right there. Now you're pointing underneath your eye there. Do you have the same pain on the left side, or is it only on the right side when you open your mouth like that?
It's a little better on this side, but it's
much worse over there. Oh, good job. Good job. Okay, very good. Now the next thing I'm going to ask you to do is to take that right hand as best you can and see how far you can get it before you have to stop, okay? Behind your head. Atta girl. Bring your head up straight. Straighten your head as best you can. You don't have to go all the way. Just, we want to know what you can do. Remember? Okay. That's it right there? Very good, Myra. Now, the next thing I want you to do is tell me, you can point with your other hand. Where did you feel the pain most intense when you did that?
I felt it in my shoulder and by my elbow.
And your elbow. But your hand was okay?
Yes.
Oh, pretty much. Okay. Now, I want you to do the same thing with your left side. Can you do that? Keep your head straight now. Maya, keep your head straight. Atta girl. There you go. Now, you're doing better there, aren't you? And where do you feel the pain when you do that?
It's the same as yours.
Same on the shoulder. Yeah. Very good. Now, the next thing I want you to just take that right hand out in front of you, please. Open and close it as fast as you can. Atta girl. Good job. Good job. Now, where do you feel the pain when you do that?
My wrist and some of my fingers.
Does it get above your elbow when you do that?
Just a little bit.
Just a little bit? Okay, good job. Now, I want you to do the same with the other side. Open and close as fast as you can. Atta girl. You're a little faster there, aren't you? Yeah. And where do you feel the pain when you do that?
My wrist.
Okay, very good, very good. And now this tingling, you're still having this tingling going on?
Yeah, my fingers.
But not as bad as it was before, still a little better. Is that correct? Okay, excellent, good job. Now the next thing we want to do here, Maya, is you see how we've got you marked here? I want you to close your eyes, bring your little trousers back a little bit, that a girl. I don't want, pull over here, hold that back so she doesn't have to think about doing that. Just hold that back so we can get you. I want you to start up here where you don't feel it, and I want you to come down, okay? Go ahead. Close your eyes, with your finger, nice and slow. And again, you stop when you think you get to where right there. Very good. Don't look. Now I want you to start over here. See where my finger is? Start over here and do the same thing. Stop when you get into it, okay? Keep your eyes closed.
Right there.
Perfect. Good job. Finally, we want you to start right there and do the same thing. Atta girl. Good job. Stop when you get to it.
Right there.
Good job. You did a great job. Perfect. Now, next thing we're going to do is going to ask your mom to help you. She's going to get over here. And she's going to hold your foot up. Oh, go over here first, please, on the right side. She's going to hold your foot up, and she's going to ask you to try to wiggle your toes as best you can, okay? Can you do that as best you can? You giving it everything you got there? Is that right? I can tell by looking at you. You're giving it everything. Okay. Now, we want to see if you can rotate your ankle for us. Can you do that? Can you do that? Okay, Mom, you don't see any movement, do you?
No.
Okay, very good. Now, Mom, I want you to get on the other side. We're going to do the same thing. Then we're done, okay? You're doing a great job. You're doing a great job. Okay. Again, Mom's going to lift it up so we can see if we can get any movement at all on those toes. See if you can move those toes for me. A little bit, not much. Okay, now see if you can rotate your ankle in your mom's hand. Can you try that? Not much, huh?
But I felt a little.
She felt, your mom says she felt a little, right, Mom?
Yes.
Okay, Mom, very good. Good job. You can put that down. Now, Myra, would you like to have a blanket or something over your legs, or are you okay like that?
I'm okay.
Okay, Mom, have a seat, please. Okay, so don't worry, I don't pick on moms. Only a little, a little way. Come over a little closer over here. Okay, very good. And of course, one of the things, the second thing, of course, is make sure you bring your she brings her black bag with all that regimen stuff. You know what I mean?
Yes, we have it all.
Because she's got it all, right? Very good. Excellent. So yeah, now you did see the 12-minute video. And did you have any questions at all about anything that you saw there? Anything?
I had questions about the short memory loss.
Sure.
How, in her case, how bad is it going to be? And how long will the short memory loss last?
Yeah, good question. We want the short-term memory to be really bad. Really bad. But her long-term memory should be intact. So if I ask her to remember, if she can remember me telling her that her mom has got a visitor, you know what I'm talking about,
Yes.
Mom? That she'll remember. What did I just remember about you? What did I just tell you I saw in your mother? What did I see? Do you remember?
Visitor?
A visitor. You know what that is, don't you? See, so I do pick on moms too, don't I? She remembered that. But when she's on the ketamine, I don't want her to remember that. We want to but if I ask you, what country do you live in? You can tell me what country.
United States.
Yeah, perfect. So that part we want to keep intact, okay? So that's the balancing act we want to go for. Now, I did mention to you, of course, obviously, number one priority, well, for me, is safety. Always safety is number one. Number two, Maya has to be comfortable. If she's not comfortable, we can't get the dose up, okay? So I have to do everything I can to make her comfortable. So we're going to give her something for nausea before she comes in. We'll give you a script for that today.
We already have it.
Oh, you got it for the 25? She's 25 kilos? Okay. Yeah, so we got that taken care of. And then, so the third thing is that I want to make sure we get accurate measurements, okay? That is critical. So I'm going to be focusing a lot of my attention. For example, each day we're going to be doing pain thresholds, okay? And we'll see what kind of progress she's making in that regard. But we really won't know really where she ends up until she goes away for the weekend. And we see, for example, we're going to look and see if her temperature control is better. Because remember, everybody in the room can be comfortable except Maya. She's not comfortable. She's either too hot or too cold, right, Maya? And so we want to see if that improves. Little things like that I can't capture here, but the other things I can capture, which are on the objective side. So we get as much information as possible, okay, during this whole experience that we have here. Now, let's see. I asked you if you had any questions. Do you have any other questions, any other concerns that you want to bring up?
I do.
Yeah, go.
What do you think
Oh, by the way, I didn't answer part of it. The other part of the story is, as soon as we turn the ketamine off, she is going to come back real fast. And you'll say, give her some more ketamine, okay? No, seriously though, it redistributes. Once we turn the infusion off, it leaves the brain very fast. So she'll be like she was on a VCR pause button,
Okay.
And so she'll come back real fast. Now, what happens usually is after ketamine infusion, most people, including the kids, are a little kind of tired, okay? They like to go take a nap for maybe 5, 10, 15 minutes, and they're ready to go out and eat, okay? But some just are so hungry because remember, they hadn't had anything after midnight. They just want to go eat, and that's fine too. Okay. But I'm just telling you typically exactly what happens in that regard. But a short-term memory, she'll bounce back real quick. Okay, no question about that. Yeah. I'm sorry to interrupt you, but you had another question.
Yes. So I had a question about the dystonia. How quickly, what are your expectations for the dystonia to go away after the treatment?
Sure. This is another good question. Okay, so here's what I expect. Number one, I expect her pain to go down significantly, long term. I expect her to improve movement. Remember, she can't even move her left foot there. Okay, correct. I expect to see that. The dystonia is going to take time. Why? The reason is this. This has been this way for a long time. And as a nurse, you start to get what we call contractures. In other words, things get fixed, frozen, so to speak. Okay. We're going to work that out with the heated pool exercises.
Following Maya's assessment with Dr. Kirkpatrick, Beata posted the following photo on her blog of Maya with the caption, "After we received the dreadful diagnosis of RSD-CRPS, my mom and dad accepted it with relief, despite its chronic prognosis, and only possible remission with ketamine therapy." She also wrote, "My wonderful mom and dad did not give up on me and kept searching day and nights on the internet. I know I was not crazy and the pain wasn't all in my head. We finally saw a wonderful doctor. At least now we have a diagnosis that we could work with, focus on, treat, but not cure. It hit me probably in a week or so on how severe my diagnosis was and how dim the prognosis may be." So, we are now at the point in the timeline where Maya gets ketamine infusions from Dr. Kirkpatrick. As will be seen, she then goes on to have a further 55 ketamine infusions with Dr. Hanna and is placed in a 5-day ketamine coma in Mexico. It seems to me that the issues related to ketamine generally are: 1. Is it required, or are there less invasive treatments a person can try first? 2. How should it be administered? This can range from a nasal spray, to orally, to an infusion, to, in this case, being put into a ketamine coma. 3. What should be the protocols and procedures for safe administration? 4. What dosage should be used, for how long and how often? 5. Are repeat treatments needed, and if so, why? 6. What are the short-term and long-term risks? And 7. Has enough research been done to know all the answers? Especially when the patient is a 9 or 10-year-old, as Maya was then. Here, Dr. Crane talks about some of these issues. I will start this part by playing clips from a podcast featuring Dr. Caleb, founding co-director of the Center for Drug Safety and Effectiveness at Johns Hopkins School of Public Health. He talks about the off-label use of ketamine and how it is being marketed.
Ketamine is an NMDA antagonist, so it blocks a particular neurotransmitter in the brain. And interestingly, there's a fairly rich history of the development of these types of products. In fact, the first was PCP, which everybody knows is an illicit drug, but not one that's certainly not prescribed or dispensed in modern healthcare systems. And while it was developed as an anesthetic in the 1950s, its potency and its dissociative properties, in other words, causing people to feel like they were outside of themselves, essentially led to its abandonment. And ketamine was a follow-up to PCP, was sort of a cousin of PCP, and was developed in the 1960s and used as a battlefield anesthetic in the Vietnam War, and also used clinically in healthcare settings. But I would say the settings where ketamine was developed and was historically used were highly regulated and supervised, inpatient healthcare facilities. We'll get to this, I know, but not how ketamine is being used in 2024.
How is ketamine being used, as we say, off-label?
Yeah, well, in lots of ways. I mean, to some degree, this is the wild, wild west when you start looking at how ketamine has been marketed and promoted. And there's an interesting loophole in the laws governing marketing and promotion that we can talk about. But suffice it to say that ketamine is now marketed for the management of any number of different illnesses. So depression, anxiety, post-traumatic stress disorder, and chronic pain are the biggies. Often the case Enthusiasm and marketing and promotion can sometimes get a bit ahead of the evidence, and that's essentially where we're at with ketamine. In the case of ketamine, you have the fact that the product is being marketed and promoted by clinics and by telehealth companies that aren't manufacturing the drug. And the laws and regulations that we have governing marketing and promotion were written in an era before the era of telemedicine and telehealth and these sort of stand-up clinics where it's not the drug manufacturer marketing ketamine, it's these other entities. And there's a patchwork of regulations governing what these other entities can and cannot say. But suffice it to say that if you look at the claims that are being made by them regarding the safety and effectiveness of ketamine, they range from sort of potentially misconstruing the evidence to being pants on fire, bald-faced lies. So there's been a lot of concern on the part of many people that have been watching this closely that there's this enormous loophole, essentially. So when it comes to effectiveness, there is a remarkable dearth of evidence of well-controlled, randomized, blinded trials, which really represent the gold standard for how we assess effectiveness. Many of the trials only look short-term, not long. They don't look at moderate or long-term outcomes of effectiveness. And the measures of effectiveness are often quite limited. And then we get to safety, which is really where things open up, because this is a drug that is ketamine that affects perception, hallucinations, visions, and such, mood. It can cause things ranging from euphoria to suicidality, affects behavior, and with a range of behaviors, sedation all the way to violence, and cognition, typically reducing, not enhancing cognition. And the real concern, the biggest concern, is that the effects aren't always short-lived, and the onset of these effects isn't always immediate. And so you have a drug that has unclear efficacy or unclear effectiveness with some very well-described dose response, cumulative adverse effects that are really non-trivial and that run all the way up to fatality. Another place where it's a bit of the wild, wild west. This is a drug that should be administered in highly controlled, highly supervised, structured clinical settings. Most concerning is that it's being used in non-healthcare settings. You can actually, in some places, get this drug compounded by a pharmacy for in-home use, which is really asking for trouble. But even short of that, the drug is also being used and delivered in cash-only clinics. These clinics can purchase a vial for less than $100 and charge $500 or $1,500 for an infusion. Insurers may not cover it, and the non-anesthesia uses aren't FDA approved. As we said, these are off-labels. Again, efficacy, unclear, but the efficacy of a lot of things is unclear, but I'm not falling asleep worried about people taking turmeric. But this ain't no turmeric. And I think that this is it's a really potentially dangerous controlled substance with some very, very well-described adverse effects and safety concerns. And we haven't discussed at all cardiovascular, urogenic, bladder, and so on and so forth. Neuropsychiatric, they go on and on.
In relation to ketamine use with CRPS, a 2018 article reports the results of a survey with 351 medical professionals who were asked to provide information on their usage of ketamine for treating the pain associated with CRPS. The article states, while ketamine infusion therapy for CRPS has been an occasional approach for decades, recent interest in non-opioid treatments has spurred new attention to various types of infusion therapies. In the United States, there has been a national increase in the use of such therapies and a dramatic increase in the number of centers performing these procedures. Unfortunately, research has not kept pace with this trend. They further stated, although ketamine shows some promise in the treatment of CRPS, there is not sufficient evidence to recommend routine use of ketamine. The setting for an infusion needs to be ICU level, with full advanced cardiac life support capability for proper monitoring and control. Consensus group participants do not endorse the use of anesthetic doses of ketamine, that is, ketamine comas. They also provided protocols for the administration of ketamine infusions, such as dosages. Here, Dr. Crane, professor of anesthesiology and pain medicine, talks about the use of ketamine at Stanford University Medical Center and also the dosages given to Maya.
Is there a role for ketamine in the treatment of pediatric chronic complex regional pain syndrome?
We do use ketamine at Stanford. There's a number of places around the country, a small number of places around the country, that use low-dose ketamine in children. There are still many, if not most, children's hospitals, if they have a pain service, restrict the use of ketamine to the intensive care unit environment in any dose. We have a more liberal hospital, and we were able to convince them that using low-dose ketamine outside the intensive care unit is safe. And it's something that we reserve for refractory cases that we cannot make better after a full court press, which would be intensive physical therapy every day for weeks, typically 10 or 12 weeks, psychotherapy every day for the same period of time, and using all the drugs that we have on the shelf that are to some degree effective in CRPS. If those things don't work, we will then put the child in the hospital for a 5 to 7 day ketamine infusion, but as I said, it's a low-dose ketamine infusion in contrast to what was used in Maya. Ketamine, you have to realize, is a drug that has traditionally, conventionally been used as a general anesthetic. You can put somebody to sleep and operate on them with ketamine. The dose that is necessary is a starting dose of about 1 to 2 milligrams per kilogram given intravenously. So that would be about 27 milligrams to 50 milligrams in somebody the size that Maya was back then. In an adult, it would be 70, 100, 150 maybe milligrams. And then about 3 milligrams per kilo per hour will keep them asleep in order to do an operation. So you can take somebody's appendix out at 3 milligrams per kilogram per hour.
How does that compare with the dosages that were used in this case by doctors Kirkpatrick and Hanna?
Kirkpatrick started around, I think, 1 milligram per kilogram per hour, and over 4 days ramped it up to 2.5 milligrams per kilogram per hour. I don't remember what Hanna's starting dose was, but it was substantially higher, and went up even higher and higher still, so that by October of 2016, he was using doses in the range of 25 to 30 milligrams per kilogram per hour, 10 times the typical anesthetic dose for a patient.
During the trial, Dr. Cantu is also asked about the risks of the ketamine comas. He is speaking through an interpreter.
There has been some discussion here about warnings of this procedure as a 50% chance of death. How does this relate to any other medications that might be used to treat this illness?
Predicting risk of a severe adverse effect is very hard to do. Like when you're going to have a certain procedure and require general anesthesia, there's definitely a risk of some severe adverse effect. When we get to the use of ketamine is before all prior treatments have failed.
How many patients had you given it to?
Most likely it was more than 25 patients.
And was this the youngest patient you'd ever treated this way?
To my recollection, it was.
Oh.
Correct.
Correct.
And so, and that was because the coma is a sort of last resort, correct?
Correct.
Correct.
And that's because it is a high-risk procedure.
It has a high risk.
And you tell every patient that.
Y usted se lo dice a cada paciente.
Correct.
Correct.
And that's not just because of the ketamine, that's also because of the intubation.
Yes.
That's right.
And the length of the intubation.
Correct.
Correct.
And the impact of ventilation for 5 days.
Yes.
That's right.
And then the risk of infection from all of that.
Yes.
That's right.
And then the effect of all the other drugs besides just ketamine.
Sí.
Dr. Hanna says he has put more than 25 people into the ketamine coma. The ketamine coma study page on Dr. Kirkpatrick's website indicates that there may have been 34 participants. However, I have been unable to locate any research papers, which I find surprising given the duration of the research study and how controversial it may be considered. Going back to the timeline and Beata's blog posts, on October 5th, Beata wrote in her blog, as if she was Maya. My first ketamine treatment was the week of October 5th, 2015. Usual infusion takes 4 hours and it's done over 4 consecutive days for a total of $10,000. My parents took home equity loan and my sister started a GoFundMe fund to offset all the costs associated with these treatments: office visits, hospital stays, food, etc. On October 6th, Beata wrote, Tuesday was a lot harder than I ever dreamed of it to be. I had hallucinations with monsters. My poor mom was mentally, physically exhausted. My dad was home with my brother Kyle, so I had only my mom to lean upon and support me through this weird journey. It felt like it was just me, my mom, and the ketamine taking this bizarre, curvy, bumpy road to fight against RSD CRPS, while waiting for my dad to come and help us stumble along. On October 7th, Beata wrote, Wednesday was a little better day. We summoned my daddy Jack to help us during our next ketamine infusion. My hallucinations were a little less today and less scary than the other day. I was calling and reaching up high with my hand to touch Jesus. My mom told me so. My mom kept reminding me that Jesus and Mary are both here in the room with us, guiding Dr. Kirkpatrick's wisdom and his hands to get me healed. At one time, I told my dad that I had to go now. I have to touch and talk to Jesus. On October 9th, Beata wrote, Friday was my last day of ketamine treatment. At the end of the infusion, my O2 went down to low 70s and I couldn't breathe well on my own. I got close to getting intubated. Luckily, with some breathing support techniques from my parents and Dr. Kirkpatrick, I stabilized after a while. Beata also posted this photo with a caption, After ketamine infusion laughter-filled dinner time at Olive Garden with my mommy. The following are clips from Dr. Kirkpatrick's YouTube video of Maya's ketamine infusions.
4-day ketamine infusion outpatient. The patient tolerated up to 135 milligrams per hour of ketamine without any serious complications.
That's not unexpected. And I would say she hasn't had any adverse hallucinations. Would you agree with that?
I agree with that.
Okay, all right. So Maya, there's one question. Are you ready? Show me the sign, Maya. Show me the sign. There you go. Hey, she's got it. She's got it. She's got it.
The following is Dr. Kirkpatrick's video of his post-ketamine infusion assessment of Maya.
Post 4-day ketamine outpatient infusion.
So we just did your pain thresholds a little while ago, and there was clearly an improvement there throughout your body. Okay. Now, are you ready to do some testing? Do 2 vertical fingers in your mouth and tell me you still have that pain under your eye, and if so, if it's the same or if it's decreased. Go ahead, tell me.
It's the same.
It didn't improve? Can you open your mouth better now? What do you think?
It hurts a lot more when I open my mouth.
Well, I know, but we're talking about how it compared to where it was before we gave you the ketamine, okay?
It's about the same.
Yeah, all right. If it's difficult to tell, it's difficult to tell, okay? Now, the next thing we want you to do is we want you to take that right hand and sit straight and see if you can get that hand behind your head a little easier now. Do as best you can, right? Right about there? That's it? Okay. And where do you feel the pain when you do that?
On my shoulder.
In your shoulder? Okay, very good. Is it about the same, or is it less, or what is it?
I don't really remember.
That's fine. That's fine. Remember, we just did it just a few moments ago. We had put you through some exercise, so we got her worked up a little bit from that prior exercise we did on her, some testing. Now do the left side for me. See if you can get that up a little easier now. Well, you couldn't get it quite back there before. You're getting a little bit better with that. Okay, very good. Again, it's his shoulder that's causing a lot of the pain. Okay, very good. Got it. Take that right hand out in front of you. See if you can open and close a little faster now. See if you can get that open and closed. Seem a little better there? Yeah. Now do the left side, please. There you go. Good job. Now, Mom, come over here and so we can see that black mark on her leg. Can you get that back for us, please? I'm going to see if, okay, I want you to close your eyes. Remember how we did that? You're going to go above the black line, so let's get it up there.
Close your eyes.
Wait, right here?
Start right there and close your eyes.
Close your eyes and work your way down until you get to that area that feels like right there. Okay, now take another area. That's right, over there. Now work your way down.
Right there.
Okay, very good. Now do the inside of your thigh over here. The other side. There you go. And that'll be it. Go down until you feel it. Right there? Okay, very good. I would say it's really hard to tell that there was a real shrinkage there going on, okay? It's kind of hard to tell.
Yeah, maybe a little bit.
Maybe a little bit, right. And I think the comment was that from a subjective standpoint, you feel she's sitting better. sitting up easier now than she did before. Now, next I want us to see if we can get any, Mom, why don't you come down there and get that foot so we can do some testing down there on that foot action. See if she's got any motion in that foot there. Go ahead and see if you can rotate that ankle for us, okay? There we go. Okay, rotate the ankle. See if you can get it. Any movement there, Mom? Okay, try to wiggle your toes for me. Can you do that? Can't do it. Okay, very good. Now, and I'm recording. Look at me. Look at me. Okay, now do the other side. Okay, well, you need a rest or are you going to be okay? Okay, see if you can wiggle those toes for me.
There was a little wiggling.
Yeah, a little bit of wiggling there. Now try your ankle there. Little movement there?
Yeah, a little bit.
Okay, very
Tiny
good.
bit.
Tiny bit.
Stop touching.
A little bit is enough. Yeah, that jerking is kind of typical of what we see, when they get, a lot of pain, going on. Mom, have a seat, please. Now, yeah, I told you that I'm confident that she's going to improve from this point, but let me tell you how that's going to happen. It's going to happen with this thing we call heated pull exercises. 3 days a week, for no more than 20 minutes every time, okay? She wants to do more than 20 minutes, she's going to do more than 3 days a week, okay? You don't get any benefit. Because let me tell you what you're going to do, Maya. When you get in the water, you're going to swim laps as best you can, okay? If it's only 5 minutes or 2 minutes, that's all it is, okay? All right. Now, I gave you 4 reasons why that works, right? Number 1, it's buoyancy. It takes off the weight bearing. She's not ready for weight bearing exercises. 2, we said the water can continue to desensitize the skin, okay? All right? So that is the other reason, the second reason. The third thing is, remember, the most common reason why patients have a relapse is re-injury. And water is an exercise you can do where you're least likely to re-injure yourself, okay? Now, the fourth thing has to do with stress. Let's talk to Mom over here. Mom's been left out of the equation. We have not been fair to Mom having Mom stress, good or bad?
Yeah.
Good or bad?
Oh, really good. It's so good. Oh.
It's neutral. Neutral. Remember that neutral?
Neutral. I remember
it's how you respond to it. Right. So yeah, it's neutral. It's how you respond to it. And there's some things that can help modulate that, of course. And that is, of course, physical activity. Correct. Those other things like yoga and hypnosis, they don't work for everybody, and it takes a lot of work to get into that, okay? So the fourth reason why it works is it's physical activity. So when you get in the water, you don't want to be with a bunch of kids yelling and screaming, right? You're going to relax and just concentrate on yourself, right? Get yourself a little timer. You set at the end of the pull. You don't want to think. So the timer says, when you're done, it's 5 minutes. You don't think about it. You just do your exercises. And get yourself a little portable digital thermometer so you can track with the water temperature. You don't want to get in there if it's less than 82 degrees Fahrenheit.
So now, from June to October, Maya had been brought to 4 hospitals, some more than once, including a 6-day stay at Johns Hopkins All Children's Hospital, 4 days at Lurie's Hospital in Chicago, 4 weeks at Tampa General Hospital, and she had now undergone 4 days of a high-dose ketamine infusion. However, as will be seen next, from Beata's blog posts, Maya was reported to be worse, not better. On October 15th, Beata wrote, "I started to have abdominal pain, nausea. I told my mom that day, I don't want to live this way anymore. I can't take this pain anymore. I wish I could just die." My mom responded to me that God is not ready for me yet, and I need to be fighting hard to overcome this horrible RSD because God has a different plan for me. Things got worse that night when I started to throw up in the middle of the night, worrying about destroying my new clean mattress and feeling bad for my parents for cleaning me up, changing my sheets, and losing their sleep. In this next blog post, Beata refers to having put a PIV into Maya. She was an infusion nurse. A PIV is a very thin, flexible tube that is inserted into a small vein in the arm, hand, leg, or foot. This is done to give fluids or medicines directly into the bloodstream. It can remain in place for several days. On 20th October, she wrote, "I still couldn't eat or drink, and my mom took me to ER at All Children's in St. Pete. I already had a PIV that my mom gave me, so they started more IV fluids and gave me morphine for pain. The ER doc was taking really good care of me after he spoke with Dr. Kirkpatrick and realized how serious and severe RSD is. Needless to say, the ER doc didn't find anything unusual in all my blood work in the end. I got admitted to 8SES, which was a nice change from the usual 6th floor, and the view seemed nicer too. Next week, I'm supposed to follow up with Dr. John and GI. Great, like I need another specialist added to my case who doesn't know a squat about generalized severe RSD. On November 2nd, Beata wrote, I was told there is nothing else that can help me or put my disease in remission in the US. Very, very sad news to me and my family. My disease has advanced and spread throughout my body, but I still have some hope left in me. Oh God and Mary, the Mother of Jesus, please, please help me. Please take this horrific pain and suffering away from me. I can't do this anymore. On November 2nd, Beata also wrote, I was informed by Dr. K that the only hope for me may be full ketamine coma in Monterrey, Mexico. My disease has advanced to the point that I no longer can turn in bed by myself or sit up. I'm basically bedridden. On November 2nd, Beata also wrote, I have a PICC line now and have been on IV hydration and Dilaudid PCA high doses to help take a notch off of this horrifying pain. Luckily, my mom is a very good nurse and she's been able to manage my complicated disease, IV meds, oral meds, and me 24/7 at my own home. I feel so lucky right now that I'm not staying at a hospital and that I have my own private nurse to take care of me. Beata refers to the hospital putting in a PICC line. This is passed through to the larger veins near the heart and can remain in place for a longer period of time than a PIV. Dr. Kirkpatrick gave the order for Maya to have a PICC line. On November 2nd, she also emailed a pharmacist and noted, I agree with Dr. Kirkpatrick. We can do Y-site. She is already getting NS 500 milliliters, so we could put that on a curl and pump. Over 24 hours. Once we are ready to start Dilaudid PCA, Maya will do well with a PCA button. PCA stands for patient-controlled analgesia. A pump is accessible 24/7, and the patient presses a button to administer a preset dosage of medication to alleviate pain. Dilaudid is hydromorphone, and NS is normal saline. On November 3rd, Beata sent an email to Dr. Kirkpatrick saying that she had taken blood from Maya and sent it to be analyzed, and she wanted him to send the lab backdated authorization. She wrote, could you please write a script for complete blood count DP comprehensive metabolic panel with last Friday's date, October 30th on it, and fax it to the Venice lab. I drew these labs on Friday because she was very sick again. I know I should have called you first. On November 4th, Beata then wrote in her blog as if she was Maya, I'm very weak. Can't roll from side to side anymore when I'm in bed. Can't sit up by myself in bed. I don't feel like eating or drinking. Every day is the same as the one prior or worst. I'm losing hope, and often I ask God to let me die, because I cannot handle this anymore. This is not fair. I don't want to live this way anymore. I would rather die. On November 4th, Beata then tells Dr. Kirkpatrick about Maya's new PICC line, saying, Maya's PICC is in. Yay, she then talks about dosages for Maya's medication, stating, I agree redosage suggestion from Jim and his recommendation are very reasonable. Bolus 0.05 milligrams, max dose 2.4 milligrams per 24 hours. What do you think of 20 to 25 minutes lockout since there will be a 5 to 10 minutes delay after she hits the button? To note, Jim is the pharmacist. A bolus is a single relatively large dose of a substance, and lockout means that the pump will not administer additional medicine, even if the demand button is pushed. On November 5th, Dr. Kirkpatrick then wrote a script for hydromorphone. At the bottom of the script, and below his signature, patient is terminally ill was written. During the trial, Dr. Kirkpatrick said that he had not written this addition. On November 7th, Beata sent an email to Dr. Kirkpatrick saying, I think having Narcan on hand is a good idea. She refuses to go to hospital any time me or Jack mention that to her. Narcan is a drug that can be used to treat an opioid overdose. On November 8th, Beata sent an email to Dr. Kirkpatrick saying, Maya is doing a lot better on the current dose of Dilaudid 9.9 milliliters. Complaining of very bad itching. Getting Benadryl around the clock to help. On November 8th, Dr. Kirkpatrick replied to Beata saying, Benadryl combined with opiates causes greater risk of respiratory depression or respiratory arrest. On November 8th, Beata replied to Dr. Kirkpatrick saying, I understand the risk. She has been doing well with Dilaudid and Benadryl. No respiratory depression, SATs 98 to 100%. Benadryl does not make her sleepy. She's been on it since 2 or 3 years old, and she's pretty much immune to it. On November 9th, 2015, a pharmacist then wrote to Dr. Kirkpatrick noting, I have read all the updates on Maya from Beata. We will be providing the Naxalone ASAP. With the last increase in dose demand, we ran out of room on the pump. We shall have to reformulate her hydromorphone bags with a higher concentration. C2 prescription also needs to state patient is terminal, so we can partially fill in a home infusion setting. On November 10th, Dr. Kirkpatrick sent an email to Beata saying, Today, I received a request from pharmacist, requesting that I write a script stating that Maya is terminal. I am not willing to do that. It is beyond my scope of practice. I gave you what I believe is in Maya's best interest. Maya is 10 years old, and it is up to you as her mother to do what you believe is in her best interests. I suggest you contact your local hospice care unit and determine if they have a palliative care program. On November 10th, Beata then wrote in her blog as if she were Maya, Dr. Cantu in Monterrey, Mexico accepted my case and will do all that's in his power to give me my previous life back and put this nasty disease in remission. There is no guarantees. There are huge risks involved. One of them is not waking up ever from the coma, even though that may sound very scary. The alternative of living in constant agony of pain seems like a better option to me in the end. I'm leaving this November 12, 2015 for Monterrey, and I'm giving the decision of life and death to God and to his mother Mary at this point. Jesus, please. The next part of the timeline talks about Maya's time in Mexico. To recap, from June to November 2015, Maya had been brought to 4 hospitals, some more than once. She has now also undergone 4 days of a high-dose ketamine infusion. However, she is worse. And Beata and Jack are now taking her to be put into a 5-day ketamine coma in Mexico, Dr. Cantu being the only person to undertake this procedure worldwide. And the previous ketamine coma study in Germany, having ended around 2007, not being repeated by anyone other than him, and Dr. Kirkpatrick as part of their research project, a procedure that is also not allowed to take place in the United States and is not endorsed by pain organizations. On November 14th, Beata wrote in her blog, as if she were Maya. 2 wonderful things happened today. I finally got to meet Jessica, who also has RSD, and then I met Dr. Cantu. Jess is my idol. Just being next to her and talking with her makes me feel better. She knows what I'm going through every minute of the day. Her words of wisdom are also very therapeutic and calming to me. I learned a lot today about Jess's RSD story and how she has been coping with it through all those years. We have so much in common besides being diagnosed with RSD. Gymnastics, playing piano, love for school, reading, using the same brand of shampoo, conditioner. That's kind of weird, isn't it? On November 16th, Beata wrote, guess what? I got the call tonight from Dr. Cantu and I am in. They accepted me and I'm going to get admitted to Angeles Hospital and receive ketamine coma. I can't tell you how happy and relieved I feel right now. I feel like I won the lottery. There is a chance for me. I may get rid of this horrific body. Later on November 16th, Beata also wrote, my blood work came back bad. And the worst of all, my cortisol level was 0. I was back in adrenal insufficiency. I am high-risk patient for developing infection. Sepsis during the coma. Difficulty weaning off of the ventilator after coma, needing blood transfusions. And total body failure, death as a result of adrenal insufficiency and other complications. Therefore, I am a high risk for dying. Dying, yes, that may sound very scary to any 10-year-old girl. I'm almost 10 years old. My birthday day is 10th December. But to me, it beats the alternative of constant suffering and pain. I would almost welcome death over the kind of life I have right now. I talk to God every day, and I beg him to take this pain away from me, or take me instead. I am ready to meet him, if he is ready for me. On November 16th, Beata posted a photo of Maya on her blog with the caption, my last good meal. Waffle with Nutella the day before admission to Angeles Hospital. On 17th November, Beata posted this photo of Maya saying, admitted to Angeles Hospital. On November 17th, Beata also wrote, as if she was Maya. How strange and confusing this world is. It is mind-boggling. My sister is getting married today in Rivera Maya, Mexico, and I am going into ketamine coma in Monterrey, Mexico. I miss my sister, Daddy, and Kyle. On November 18th, Beata wrote, this disease is very rare and especially more rare in children, so there is still many unknown phenomena. So far, I am the youngest child in history who has developed severe generalized RSD in a very short period of time. And I am the first youngest child in history who is going to be placed in a high-dose ketamine coma. On November 19th, Beata wrote on her blog, Ketamine Coma Day 2. The ET tube is irritating my throat. It makes me gag sometimes, and this morning it made me throw up. Thank God my mommy was right there when this started to happen, and she helped me right away. Then the rest of the nurses run into my ICU room to suction my mouth, lungs, etc. Luckily, it didn't look as if I aspirated any emesis. My mummy saved me. On November 20th, Beata wrote on her blog, today is coma day 3. Yay! I feel better today after Dr. Cantu increased my ketamine infusion to 5 mg per kilogram per hour. He also increased my Verse drip to 4 milliliters per hour and Precedex to 3.8 milliliters per hour. I have very high tolerance for drugs. If I was a horse, I would be comatose or dead already. Beata also posted this photo on her blog saying, God, please help me to overcome the side effects of ketamine. On November 21st, Beata wrote, since I am a superpower girl, I am still receiving very large doses of Versed Presidex IV continuous infusion and also extra propofol boluses to keep me in the coma. Dr. Cantu told me he has not seen a soon-to-be 10-year-old girl requiring this much of sedation. Well, what can I tell you? I'm just a very, very special little girl. On November 24th, Beata wrote, today is my last day of coma. I was finally breathing on my own. I thought the worst was over. I guess I was mistaken again. Taking each breath in made my chest hurt. Each time I tried to swallow, it felt like a million knives cutting across my throat. I finally got a break relief when Dr. Cantu came back and knocked me out with a propofol infusion. It was the best thing ever. I didn't feel anything anymore. I was sleeping again. Thank you, Jesus, for propofol. Beata then wrote, I was a lot of work today. I needed my mommy constantly to help me, comfort me, and to advocate for me. I wouldn't let her leave my bedside for even 1 minute. She was going through her purgatory on earth. She was my mommy, my nurse, and my angel. My biggest surprise came in late in the night. Daddy flew in from Florida to see me and help my mommy. I was so happy to see him. Next, on November 25th, Beata wrote, Maya asks that you please watch her YouTube videos of when she was in ICU in coma. And please do share them with your friends and charity organizations or social networks, so they may also have an opportunity to donate to help pay for the enormous costs of her treatment. This video was shown during the trial.
Understand that difficult times can make me stronger in the end, even though it may not always be easy to see. God bless you. Thank you. Maya is moving her arms. She's strong. She loves you all. God bless. Everybody loves you, okay? Babcha Chesha loves you. Grandma loves you. Everybody. We're so happy. We're so proud of you. You're doing just wonderful. Okay? One more day. Tomorrow you're going to be awake, okay? We love you, honey. Bye.
On November 30th, Beata also wrote, the ketamine coma does work. I am a living proof of it. There are also 31 other patients who underwent the research ketamine coma study in Monterrey, Mexico, and all of them survived and got better. Those people are also a proof that this treatment does work. Whilst in Mexico, Beata posted this photo in her blog with the caption, I love Jessica, who helped me so much through my ketamine coma, and I love Dr. Cantu, who extended my life and improved the quality of my life. You both rock. Beata also posted this photo on her blog with the caption, I'm very thankful for my first Thanksgiving dinner with the Steves family. I'm especially thankful for Aunt Sarah, who cooked such a delicious turkey dinner. Aunt Sarah, you are an amazing chef. I am also very thankful for my daddy, who came to see me in Monterrey. Sarah Stevens is Jessica Stevens' mother. Beata posted this photo saying, I'm very thankful for Dr. Cantu, who gave me a second chance of life. She also posted this photo of Maya with the caption of daydreaming, when will I stand and walk again? And this photo of Maya in her wheelchair with her legs raised at a shopping mall in Mexico. So, now going back to the timeline. From June to December, Maya had been brought to 4 hospitals, some more than once, including a 6-day stay at Johns Hopkins All Children's Hospital, 4 days at Lurie's Hospital in Chicago, 4 weeks at Tampa General Hospital, 4 days of a high-dose ketamine infusion, and a 5-day ketamine coma in Mexico. On January 6, 2016, Dr. Kirkpatrick met with Maya and Beata for a post-coma assessment. Of note, he refers to the ketamine coma being in December, however it was November.
Ketamine coma, she was induced in December, okay, and it was December, what was it?
18th.
18th, okay. So she went through the 5-day ketamine infusion. Why did we elect to do that after trying to get her under control with a 4-day outpatient ketamine? Because her response was not definite enough, clear enough that we could, the more ketamine infusions was the way to go. But keep in mind, as your mom knows, since she's a nurse, going in intensive care unit is much higher in risk, much higher. Not to mention how it is when you come out of the coma. I mean, going into the coma is no problem, right, Maya?
No.
Isn't that right?
Yeah.
Tell us about how it was when you came out. Was it pretty bad news?
Yeah, I did not like it. I felt like I couldn't breathe. I was coughing like crazy, and I felt like I couldn't breathe.
Right. So it's important to tell it like it is. That's right. It's tough. Now, but Now, having been through all that, was it worth it?
Yes.
Look me in the eyes and say, Dr.
Yes.
Kirkpatrick, it was worth it.
Yes, Dr. Kirkpatrick, it was worth it.
Okay. All right. So she was going. Mom, tell us why, in your view, why we went ahead with the ketamine coma. What was your take on that?
Maya was getting worse. Her pain was getting worse every day. She couldn't move. She couldn't roll. It was constant agony of pain, 24 hours a day. No sleep, no eating, no drinking. She started to have abdominal pain. She had to be started on IV hydration to help her at least get some fluids, because she wouldn't even touch water. She couldn't take pills anymore because everything was hurting her even more.
Right. And Maya, I think you made the point that you just didn't really want to continue, did you? You'd rather be in a coma and then continue the way what life was going for you, right? Am I correct on that? Right.
Maya did say several times that she would rather be in a coma or die than live like that.
Now, after the ketamine coma, she went back for 3 days of some ketamine boosters, low dose type stuff, and that was about 2 weeks afterwards, 2.5 weeks after, something like that. And that seemed to help.
It's helped a lot.
Yeah, helped a lot, especially with the headaches, if I understand
her
correctly.
headaches are a lot better.
Yep.
They're minor now.
Right.
Her pain in the legs is better.
Right.
So, so
right.
it's all better.
And she couldn't cross her legs before, but now she can cross her legs and do that sort of stuff. So let's do some testing on you here, Maya. Are you ready for that?
Yep.
Okay, 2 vertical fingers in your mouth. See if you can do that now. You couldn't do that before without having a lot of pain in your face. Is that right?
Right.
Right, okay. Now the next thing, I want you to just take that right hand, put it behind your head. You couldn't do that. No way before. No, any pain when you do that?
Not really, no.
Not really. Okay, now do the other side, please. Again, you couldn't do that before. And we talked about how important it is that you have the mobility and be able to use your hands, right, to take care of yourself. Otherwise, that's major, major problems, right? Okay. Okay, the next thing we want to do on you here, remember you had this real sensitive leg, so show us where that black mark is there. Okay. Okay, there's that little dot. Now show us where the other one we made earlier today. It's right there. You see that? Oops, there we go. You see that there? That's where we were before. When you left here and you went for the ketamine coma. You couldn't go below that without feeling like your skin's being torn off, right? Okay. Now go ahead and close your eyes and start there and move down. Stop when you get into that, like a road burn sensation, remember?
Right here.
Yeah, so it's shrunk down, right? Does it feel the same as bad as it was before, or is it just, or tell us, just tell us.
It feels kind of the same.
Okay, that's fine. It's fine. And listen, we talked about sometimes it takes time to overcome those sensations, right? Now, let's take a look at your feet down here. You see how her feet are curved in? That's because they weren't moving, and she's got some what we call frozen. She's kind of frozen. That can be straightened out with the heated pool exercises, okay, over time. But some things just take time. That's going to take time, okay? And I know she has been, up until recently, until it got kind of cold here in Florida, you've been exercising at least in the water 3 days a week, right? Right. Mm-hmm. Okay. But you're going to get into some heated pool exercises, probably indoor, 3 days a week, no more than 20 minutes each time, and she's going to try her best to do laps, right?
Yeah.
Okay, good. And we want to get those feet straightened out there, okay? Now, let's do this just for the record. I remember you couldn't move that foot at all on that right side. See if you can wiggle those toes at all now. Go ahead. See if you can wiggle. A little bit of movement there. Okay, good. Now do the other side, please. Can't really move that right. Correct? Okay, so we're going to keep track of that. Now, okay, and the other thing I want to ask you, and I did ask you this earlier, Maya, is it okay if we can use this video to educate other children?
Yes.
That's okay with you? Let's check with Mom here. Is that okay with you, Mom?
That's okay with us.
Okay, very good. All right, now listen, let me see if anybody has any questions. Mom, do you have any questions?
The only question I have is, the tremors. She seems to have a lot of tremor in her hands.
Sure.
Well, it's more evident with the hands, especially when she's trying to write.
Sure. Sure.
Is there something we can do to help that?
Sure. There is, and that's where the heated pool exercises come in. Yeah, and that's a normal response. Okay, it's like, think of it as, that's just what happens, and that'll go away. Just like I think your feet are going to straighten out, but it's going to take 4 or 6 months. I'm sorry to tell you. Those things, there's just some things that take time, and that happens to be one of them, okay? And I'm confident it's going to happen, especially in your case, because I know you're very, very dedicated, okay? How about you, Maya? Do you have any questions?
No.
Okay, all right. I have a question for you. You ready?
Yes.
Do you have a boyfriend? Do you? Do you have a boyfriend?
I'm not telling.
People want to know.
No, they don't.
Talk about putting somebody on the spot, huh?
The ketamine coma procedure resulted in a far greater improvement in the patient's clinical outcome than the 4-day outpatient ketamine treatment. There was a dramatic improvement in strength and range of motion, as well as the ability of the patient to take care of herself, especially in her upper extremities. Dr. Kirkpatrick asked Maya, "Now, having been through all of this, was it worth it? Were there problems?" Maya described difficulty breathing when she awoke from the coma. Maya was asked, was it worth it? Yes, she said, with a smile.
On January 13th, Maya then had her first consultation with Dr. Hanna. So who is Dr. Hanna? He is a board-certified anesthesiologist. He runs a clinic in Florida with websites called No Pain Hanna and IVketamine.com. This is also from one of his adverts, where he says he has provided 8,000 infusions and is the world's leading ketamine doctor. Dr. Hanna has many videos on his publicly accessible YouTube channel. For example, this one, where he refers to dramatic results with IV ketamine. The YouTube description also stating that this patient has CRPS.
Hi, Lauren. Okay, sorry, can you show me the range of motion for your arm? Can you lift your arm up? Okay, that's as high as you can go? Okay, can you bend your elbow? Good, yeah, can you straighten it up all the way?
No.
Okay, show me your hand. Can you open up your hand or no?
That's it.
That's the maximum. Can you close it? Okay. How are you, Laura?
Very good, Dr. Hanna.
Okay, can you show me how you can move your arm right now?
Yes, I can.
Wow.
Very
Look
good.
at that. That's a lot better than before.
Yes.
Okay.
Yeah, I got muscles.
Okay. Okay, so this is now day 10 after the ketamine. Okay, so proud of you, Laura.
Thank you.
Awesome.
I would be interested to know more about the long-term outcomes for his patients, or how he explains the progress in a case like the one depicted. Dr. Hanna also has videos from talks he has given. In his talks, what first caught my attention were his statements that regional should be replaced with central, as CRPS will spread to all limbs, the whole body, face, head, and everywhere.
I would like to give a brief presentation about CRPS, which I personally believe it should be called CCPS. CRPS stands for Complex Regional Pain Syndrome, but we believe it's more of a complex central pain syndrome, since really it affects the whole body, as any one of CRPS patients now experience. CRPS, but it means complex regional pain syndrome. It was initially reflex sympathetic dystrophy. The nomenclature was changed to complex regional pain syndrome. I personally believe that it will change again. It will have to, because it is not regional anymore. It can start regional, but it will eventually, in definitely a decent number of patients, become a whole body a disease, a whole body disease. And it will spread to all limbs and the whole body and the face and the hair and everywhere.
He also gives his views on the Budapest criteria.
If you think it's CRPS, treat it as a CRPS. If it does not fit the Budapest criteria, we made those criteria just to make it easy for us. That's not a law. Those are just criteria to help. If you think it's CRPS because that's you see sensitivity, you see swelling, but you don't see a couple of other criteria, if you doubt it is CRPS, treat it as a CRPS. Be aggressive with it. You can be wrong, that's no problem. And it's not a problem if patient didn't have CRPS. Most likely it's atypical CRPS. It's some type of neuropathy. They're all related, central sensitization. It does not have to fit 100% the criteria. I mean, right now, I urge every doctor to get an infrared camera. It's very simple. You can diagnose the asymmetry in the temperature immediately in 1 second and document it and move the case. Get ketamine immediately.
He also states that he believes that ketamine should be the first line of treatment.
I will do ketamine as the first line. As I said, in the past, it used to be, oh, last line is the ketamine. Now it's the first line because that's the only treatment that addresses the pathophysiology of the disease.
And here, he comments about suicide amongst his patients.
Well, the worst case I've seen are the one who committed suicide. Because suicide rate is very high, extremely high, among CRPS patients.
Despite Dr. Hanna's apparent assertion that the term regional should be removed from complex regional pain syndrome, the term regional is there to differentiate CRPS from other chronic pain conditions. It's important that when learning more about a syndrome, all clinicians and researchers apply the diagnostic criteria in the same way. In this case, the Budapest criteria, the gold standard used worldwide for the diagnosis of CRPS. If Dr. Hanna is not using these criteria as they are intended, this may account for him stating that Maya has CRPS when 40 other doctors had different opinions regarding the reasons for her presentation. I also note that Dr. Hanna states that ketamine should be the first line of treatment used for CRPS. Again, this is not supported by the evidence base. Regarding suicide. As mentioned earlier in this video, there is no evidence that people with CRPS are at a higher rate of committing suicide than their peers. However, if a person was wrongly diagnosed as having CRPS, when they have a somatic symptom disorder, and are given ketamine, instead of treatments by a multidisciplinary team, which includes psychologists and occupational therapists, then yes, they may be more at risk of suicide. Sadly, that does not seem to be acknowledged by those for whom maybe it should. So, going back to the timeline. In January 2016, Maya started having ketamine infusions, provided by Dr. Hanna. The following part looks at February to June 2016, with information taken from Beata's blogs, as well as medical records and footage shown during the trial from this period. On February 2, 2016, Beata wrote, "I was doing so well until the evening of January 13, 2016. Around 8-9 p.m. on January 13th, I developed a massive headache and blurred vision. My mom said I looked like I had a stroke. We called Dr. Hanna's office and they managed to fit me in for urgent ketamine boosters. I honestly couldn't deal with this relapse. I told my mom I was ready to die. January 18, 2016, I went for my emergency treatment. I was there 4 long days. I seemed to tolerate the ketamine bags better this time." On March 4, 2016, Beata wrote, "The original plan was to alternate ketamine treatments with physical therapy. The plan changed. My RSD got more severe and it already has spread from my legs to head, then to back and arms. I was telling my mommy, I want my ketamine, can we go now, please?" Beata would write emails to herself. On March 14th, she sent herself an email stating on March 10, 2016, I had surgery. The doctor inserted a venous port for all future IV meds. I was crying and screaming from horrific pain and wishing I would rather die. A venous access port is a small container that is placed under your skin, usually in the upper chest. The port is attached to a catheter that enters a large vein. It is used for people who need longer-term treatments, such as chemotherapy or bone marrow transplants, or people with hemophilia or cystic fibrosis. During the trial, Dr. Hanna stated that he wrote the order for Maya to have the port placed in her. This clip was played during the trial and said to be filmed on April 30, 2016.
Okay. All right, and the date on that, the record reflects is April 30th, 2016.
On May 13, 2016, Dr. Spiegel wrote the consultation was cut short due to the patient's inability to be examined as she was in extreme pain. The extremities are unremarkable for edema or clubbing. There is no change in temperature or color of the skin. The next part is the timeline from June to August 2016, again taken from Beata's blogs and medical records and clips shown during the trial. The clip was also played during the trial, although not in front of the jury, as after asking for it to be admitted, the Kowalski's attorney said he had changed his mind. It was said to be filmed on July 28, 2016.
Again, this is Maya, and I have RSD. I'm unable to walk, and when I hear your songs, it makes me feel better when I'm dancing. So here you go. Ready?
These two videos were shown to the jury and also said to be filmed on July 28, 2016.
26:59 on July 28th, 2016.
That's better. I love you. Now go down slowly.
And what's the goal there with the
Go down
legs?
slowly. Good job.
Sorry, I did not hear your question.
Good job. Very good.
From May 2016, Maya was also getting hyperbaric oxygen therapy. In total, she had 40 sessions, each session lasting 90 minutes. On some days, she had both a ketamine infusion and a session of hyperbaric oxygen therapy. The photo is the chamber used. On August 11th, Beata wrote, "I had again 5 days of hyperbaric treatments and 3 days of ketamine infusions, 3,000 milligrams total. I felt totally exhausted. I've been very forgetful from the ketamine. Short-term memory definitely is a problem. Sometimes I can't tell if it's AM or PM. Did I eat breakfast already or not? Did I have my ketamine treatment yet? Did I go into the chamber yet? Everything is just a blur to me." These clips were also played during the trial, although the first one, with Maya doing a backflip, was not shown to the jury. They were said to be from August 12, 2016.
This was not.
2696 was not shown to.
That's correct.
It was showing that she was progressing, and I thought it was a very good thing.
But still not quite ready to walk?
Correct.
Okay, so she push herself around on her legs and like that, and obviously master a dolphin. Well, maybe not master a dolphin, but master a dolphin for a little while. And that's her wheelchair?
Yes.
And y'all kept it right in that spot?
It moved a little bit, but mainly in that area, yes.
All right, and then when she wanted to get out of the pool, how'd you get her out of the pool and into the wheelchair?
At this point, she had enough upper body strength to pull herself out and then grab the wheelchair and push herself up.
V. A month later, on September 15th, Dr. Hanna provided a letter to the school board. He wrote, "Maya suffers from horrific disease RSD-CRPS. Maya became overstressed, extremely worried and crying after her September 6, 2016 individualized education program meeting at TRS, which I strongly believe led to her RSD relapse. Maya required daily IV fluids for hydration, zofranilin V, ketamine for pain control, and many other medications to help Maya fight her RSD relapse symptom." On October 7th, Dr. Hanna then advised Jack to take Maya to Johns Hopkins All Children's Hospital. Here he is being asked about this.
Okay, so you sent her to Johns Hopkins All Children's Hospital?
Yes.
Why?
Because I failed to help her. There's nothing I could do I told the mother, that's the maximum I can do. I cannot give her any more. She has abdominal pain. I need her to go to a bigger place. They can maybe do some continuous infusion. First of all, we need to see why she's having abdominal pain. They can do some lab work, check, make sure nothing else is going on. If I couldn't control her with my average capability, with the maximum infusions I could do here, then it was time for me to send her to another facility.
So is it fair to say that October 6, 2016, which was your last infusion date with her, that was the maximum that you felt comfortable with?
Yeah.
And the patient on that day is in 10 out of 10 pain still, with pain medications. And you now went up to 1,250 milligrams plus a 50 milligram ketamine bolus, and you did this infusion over a shorter period of time, 2 hours. Which gets us to above 24 milligrams per kilogram per hour. What was the medical decision making about going up even higher on 10/6/16?
As you see, the day before she came with 10 over 10. She was screaming. She was crying from pain. Her mother stated that I cannot live. You know, she's in so much pain. She's screaming. She's up all night. This is the patient I'm having in front of me. I did everything I could the day before. I discussed with the mother. We said, okay, you know, actually the father was there. You know, and I discussed the case with him. I said, I'm really running out of option here, probably. I can try to shock her brain more, try to give her, I don't want to give her more dosing, but let's see if I give it to her in a shorter period of time that you can achieve a better result. And that was, I told him, this is the maximum I can do. If she does not get better after that, we're going to send her to the hospital.
So I think you just answered one of my previous questions. October 6, 2016, that was the maximum level you felt comfortable with, above 24 milligrams per kilograms per hour?
I had given her enough. She was not responding. There was nothing else I could do.
Is it possible, doctor, that the abdominal pain you're referencing was caused by these infusions?
I mean, it can be a side effect. As I said, it can be a side effect from, like a cholangitis or something. That's why we needed her to go to the hospital, maybe get liver function. And I don't know how her liver functions. And these are, as I said, reversible. So when I have a patient like that, I send them to the hospital. That would be the prudent thing to do.
So we have come to the end of the timeline. Up until Maya was admitted to All Children's Hospital. This is a quick recap. Between June 2015 to October 2016, Maya had been brought to 4 hospitals. She had a 6-day stay at Johns Hopkins All Children's Hospital, 4 days at Lurie's Hospital in Chicago, and 4 weeks at Tampa General Hospital. Somatic symptom disorders were reported, and the appropriate therapy was offered. However, Beata learned about CRPS and told a doctor that Maya had the syndrome before she was diagnosed with it. The diagnosis was provided by Dr. Kirkpatrick, who said that the Budapest criteria are not utilized for the clinical diagnosis of CRPS, even though they are considered the gold standard for diagnosing CRPS in any context. He also said that the 1994 guidelines are frequently referenced for diagnosing the syndrome, despite the fact that the updated version is the one recognized globally. Dr. Kirkpatrick is also involved in the ketamine coma study in Mexico. He's further noted that he believes CRPS can lead to paralysis and is terminal. Although this claim is not supported by the literature, Dr. Hanna backed Dr. Kirkpatrick's diagnosis, but he has said that he does not think that complex regional pain syndrome is regional, nor that the Budapest guidelines are necessary. He's also said that he believes that CRPS will eventually spread throughout the body, and that ketamine should be the first line of treatment. Yet these assertions are again not supported by existing literature. Maya then had 4 days of ketamine infusions with Dr. Kirkpatrick, but was worse. So she was then placed in a 5-day ketamine coma in Mexico, a procedure not allowed to take place in the U.S., Dr. Cantu in Mexico being the only person worldwide doing it. She then had 59 ketamine infusions and 40 sessions in a bariatric chamber. Beata had also put a PIV line into Maya, drawn bloods from her, and based on her report and Maya's presentation, Dr. Kirkpatrick and Dr. Hanna had given orders for Maya to have the more substantial PIC line, and later a port also placed in her. She also had a morphine pump and ketamine for use at home, as well as many other medications. Terminal had also been written on a prescription form, then, as stated by Dr. Hanna. Just prior to her admission to All Children's Hospital in October 2016, she was scoring her pain as 10 out of 10. And he has told Beata that he cannot give her any higher ketamine doses despite her wanting him to. She was also reporting extreme abdominal pain, which can be a side effect of ketamine. So, were the hospital right to suspect medical child abuse? Next, what is medical child abuse? How does it fit in with Munchausen by proxy? And what should a hospital do if it is suspected? Medical child abuse occurs when a child receives unnecessary and harmful or potentially harmful care at the instigation of a caretaker. How does that fit in with Munchausen syndrome by proxy? The adult gets the diagnosis of Munchausen syndrome by proxy, or factitious disorder imposed on another, which is the new term for it. The child is the victim of medical child abuse, and the adult is the perpetrator of that abuse. Within children's services, the focus is on the child, so the term medical child abuse is used there. Broadly, there are 3 ways that the adult will medically abuse the child. These are exaggeration, fabrication, and induction. With exaggeration, a genuine physical, psychological, or behavioral condition exists, but not to the extent reported by the perpetrator. With fabrication, the perpetrator makes up a symptom or illness, and/or makes it look as if a symptom or illness exists when it does not. With induction, the perpetrator causes a real symptom or illness to exist. What are some signs of medical child abuse? 1 is the parent reporting signs and symptoms that are not explained by medical conditions, as well as an inexplicably poor response to medication and other treatments. New symptoms are often reported on resolution of the previous ones, and the child is repeatedly brought to doctors. Often the perpetrator frequently changes the child's doctors, also known as doctor shopping. Their presentation when being told that their child may need more treatment or tests seems odd. There is often unusual or excessive sharing of health information about the child, particularly in social media. And most importantly, the symptoms may resolve in the absence of the perpetrator. However, not always, as I will come on to later. And why? Why would the person, usually the mother, do this? They may simply like attention their Munchausen by proxy behavior produces for them. They may want admiration from medical caregivers or the community about being so attentive to their sick child. Repeated hospitalizations may allow them to escape the responsibilities of parenthood, or they may need to feel the child is totally dependent on them and force this through induction of illness. They may also find gratification in manipulating high-status professionals such as doctors or prestigious institutions. They may be emotionally satisfied by gaining the attention of lawyers, judges, as well as the media. But they may also be punishing others, such as absent partners, to doting grandparents, anyone who cares about the child more than them. They may also be punishing the child. The sick child may also be used to unite them with a partner, because how could a partner leave them at a time like this? And what about the characteristics of the perpetrator? They may have a history of fabricating, exaggerating, or inducing illness in themselves. They may like being in the spotlight and may claim to have experienced an unusual number of dramatic events. They may also have a background in the health profession, such as nursing. On the surface, they may present as very attentive parents, such as always being on the ward, not taking breaks, becoming over-friendly with staff. Mental health evaluations may come back normal, and others may say, "They're the last person I'd expect to do this." And when the behavior is found out, they may deny it despite overwhelming evidence. Or they may come up with outlandish explanations. They may then adapt their behaviors, and even when separated from the child, they may be intent on still finding ways to make the child ill, so they can say, "See, it wasn't me." And what about the impact on the child? Often the abuse starts when the child is too young to understand it. The perpetrator is usually also adept at misleading teachers, family members, friends, and the child only knows the version of reality their parent has created around them. Even when, or if, the child begins to think things are not quite right, they may feel that no one will believe them. They may also feel a need to protect the perpetrator, especially if it is their mother. They may fear abandonment. They may also develop a somatic symptom disorder. This can include behaviors that they are doing unconsciously, but also behaviors that they are aware of, where they may purposefully present as being ill, but this being due to complex psychological factors arising from the medical child abuse. And what should a hospital do if medical child abuse is suspected and they are treating the child? The most important aspect is that medical child abuse is no less serious than physical or sexual abuse. And just as a child would be protected if physical or sexual abuse was suspected, a child must be protected if medical child abuse is suspected. This will often include supervised contacts. If the child remains at home, the supervising person, perhaps a partner or family member, must understand and accept the possible risks and agree to the supervision guidelines. If the child is separated from the parent suspected of engaging in medical child abuse, even phone calls will need to be monitored, as the parent can still influence the child if only speaking to them. Anything brought to visits will also need to be checked, including food and drinks, and letters and packages will also need to be opened and inspected. This is because if a parent is medically abusing their child, they may be determined for the child to remain ill, even though their contact has been restricted, so that they can say, "It can't have been me. See, they're still ill." So were Johns Hopkins All Children's Hospital right to suspect medical child abuse and contact the Department of Children and Family Services? Or is Jack Kowalski right when he said in the press conference,
"Parents have rights, and they make the decision for their children"?
Clearly, the 5-person jury agreed with him as the Kowalskis were awarded $261 million. Before ending the video, I want to give my thoughts on some parts of the trial, beginning with Dr. Chopra. Dr. Chopra is board certified in pain management and anesthesiology. In court, he stated that he was appointed to provide an independent opinion.
Now, tell the jury a little bit about how you got involved in the examination and rendering opinions about Maya Kowalski.
I received a call from the court, and I can't remember whether it was the judge himself or somebody else from the court, and I was told that they needed me to examine a patient and give an opinion.
So you weren't a formal, what's known as a CME or IME, but you understood that you were supposed to render a fully independent opinion?
Yes. So this call that I got from the court in Florida I was tasked with one job, and the job was to give my opinion about what was going on with Maya.
I note, however, that in an email to Dr. Kirkpatrick, Beata states, the court requested another unbiased CRPS opinion to be done on Maya. I suggested Dr. Chopra in Rhode Island. I'd like him to be the unbiased CRPS expert. She puts unbiased in quotes. This may be because she had looked at his website. For example, an article on his website was titled, "The Epidemic of Child Abuse Doctors Harming Children." It said child abuse pediatricians are a class of doctor, who are pediatricians, who specialize in diagnosing child abuse. This path of specialization is obviously not chosen by pediatricians who are academically good. As a result, these child abuse doctors are not the best to identify complex medical conditions, let alone straightforward common medical conditions. Avoid any hospital that has a child abuse doctor on staff. Doctor is put in quotes. Dr. Kirkpatrick also said the following. In an email to Beata, sent on November 28th, Dr. Smith is a dangerous doctor and must be disqualified as a medical expert in this case. Dr. Smith and her friends at Children's Hospital are accusing you of Munchausen by proxy, as a scapegoat to conceal their obvious incompetence in the care and treatment of your daughter. In court, he also said that he warned off Dr. Sally Smith, the medical child abuse pediatrician. As shown earlier in this video, Dr. Kirkpatrick also has a negative opinion about mental health professionals, stating they're the ones with psychological problems. During the trial, Dr. Chopra also expressed a similarly negative opinion.
Were you aware in reviewing the records that Mrs. Kowalski refused to have her child evaluated by psychiatry on admission? Were you aware of it?
Oh, yes, and I'm not surprised.
Okay. Were you also...
That's very appropriate.
Were you... So what you're telling this jury is you don't believe that Maya should have ever been assessed by a psychologist, true?
True, absolutely.
Okay.
This is an opinion that he has expressed previously. This video being from a 2017 talk he gave at a Reflex Sympathetic Dystrophy Syndrome Association event. RSD being the previous term for CRPS.
Mental health, CRPS is not a psychiatric condition. We know that. It's in the guidelines. So it's not just me saying that. It's definitely not in your head. If you meet a provider, if you meet a physician that's the first thing they tell you, I would recommend not going there. I may come off as being very blunt, but this is what you're here for this. You need to know the hard facts. If I have CRPS and the first doctor I go to see and tells me that, well, you should go see the psychiatrist next door, I'm not going back.
Whilst Dr. Chopra is right that CRPS is not a psychiatric condition, not all people attending for an evaluation will have CRPS. Some may have a somatic symptom disorder, such as a functional neurological or conversion disorder. This chart was covered in detail earlier in this video. I also note that in his report and in court, Dr. Chopra gave an opinion on Beata having Munchausen by proxy. I am unclear why, as he is only board certified in pain management and anesthesiology. He also recognized that it was a psychiatric diagnosis.
And did Maya have Munchausen, or did Beata have Munchausen by proxy?
No.
And is that a psychiatric diagnosis?
Yes.
I also noted that Dr. Chopra replied to a question asking, this time, if Maya had Munchausen by proxy. He did not clarify that the child is never given that diagnosis, as that is the diagnosis given to the adult, the perpetrator of the abuse. The child is the victim of that abuse.
And in your opinion, did this child have Munchausen by proxy? That is in the report and in the record.
Absolutely not.
A further observation was Dr. Chopra's opinion on photos he was shown of Maya.
Significant.
Okay. What's significant about the knees here?
See, you can see how her knees are different colored. In fact, the left knee is a little darker than the right, but they're pretty much the same. And this is a kind of a significant change, but if you aggravate the pain, this change becomes far more significant, far more prominent. So, ladies and gentlemen, if you look at the picture on the left side, which she's holding up her hands, that little dot there on both her hands, the one on the forehead, these are classical CRPS lesions, and these are extremely. So she has pain in the arm. We know that. That's the CRPS pain. But the lesion that she has is extra painful. And she has one on the forehead, and then she has one on each hand.
I believe there's two of those, one healing and the other one. Why the difference here?
Right. So obviously everyone can see that big line there, but right next to that line, you'll see another lightish spot. That's right. That spot is a healing CRPS lesion, and this one it started at the part where the skin is broken. I'm talking about the long one. It started where it broke, where the skin broke, and then it kind of continued. And this is not a continuous line. It's a series of blisters, and they've all connected to each other to form a line. But you can see little bumps everywhere. It's not like a scratched line. It's more like little blisters all in a line.
In these clips, Dr. Revivo and Dr. Crane also give their opinion on the last photo, whilst Dr. Chopra says that Maya had CRPS lesions. Here, Dr. Revivo, Chief of Pediatric Rehabilitation Medicine at Lurie Hospital, who also assessed Maya, said this.
Do you see the what I'm circling here on the right forehead here?
Yes.
Does that appear to you to be consistent with the type of CRPS lesions you've seen in the past?
No.
Why not?
Because it isn't. It looks like a scratch.
Okay, so why does it look like a scratch to you?
Because it does. It doesn't look like it's CRPS. There's no swelling. There's no edema. It's on the forehead.
Dr. Crane, professor of anesthesiology and pain medicine at Stanford University Medical Center, said this.
But you can see from this picture that, well, a couple of things. First, CRPS does not occur on the face. CRPS type 1, which is what we're talking about, does not occur on the face or the forehead. Number 2, you can see it's nice and pink, it's well perfused, it's got good blood flow. And number 3, it's a linear lesion. It's a fingernail scratch, I would say. I would speculate, but it's a scratch nevertheless. It's not a CRPS lesion.
Earlier in this video, I also noted how Dr. Chopra referred to something he called the McGill Pain Scale. However, I noted that there is no McGill Pain Scale, only a McGill Pain Questionnaire, and how the one he presented in court was made by someone on Facebook, along with similar ones. I noted that there was a similar chart in a research paper where causalgia was placed at the top. However, causalgia being CRPS type 2 and only affecting about 5% of people with CRPS, it involves a lesion to a nerve. I surmised that someone replaced causalgia with CRPS, and that was how the urban legend that CRPS causes the worst pain known to man came about. I am unclear why Dr. Chopra spoke about a research study that does not appear to exist. This is also what Dr. Chopra said about Maya's experience of pain.
But CRPS pain does not go away. It's there 24 hours, 7 days of the week, and it just stays on and on and on. In fact, their pain is always 10 out of 10. On a good day, on a very good, rare day, it will be 9 or 10. So we're not talking about a relapse of a little headache. We are talking about severe, she lives at a baseline pain that you and I cannot even comprehend.
You can tell physically she's doing better today than she was when she was brought into All Children's. True?
All I've done is see her from a distance. That doesn't mean that she can't be in severe excruciating pain.
However, despite Dr. Chopra saying that a person with CRPS's pain is there 24/7, 7 days a week, and at a 10 out of 10 pain level, although on a good day 9 out of 10, these clips shown at the trial from May and October 2017 This is also from Maya's deposition in 2020.
Walk me through a typical day in Maya Kowalski's life over this summer, let's say.
I wake up at 4:30. I immediately go on my walk, which lasts normally 1 hour and like an hour and a half to up to an hour and 45 minutes.
Okay. Walk me through what you do when you work out at 4:30. I just want to get an idea of the type of exercises you're doing, the duration, that kind of thing.
Yes. So I simply go around this circle here because we live in a community that is circular. I go around that 6 times, so that's 5.5 miles. And I'll do some cardio, so running. I could do some high intensity interval training, so 20 seconds of running, 10 seconds of rest, so on and so forth for however long. And then I mix that in with some power walking because obviously first thing I cannot run around the circle. I just can't do that at 4:30. So the first 3 laps, I would say, are just me walking and warming up my muscles.
It is also noted in court records that Maya was only prevented from using ketamine from January to April 2017. She was also asked about her ketamine use and pain management in the 2020 deposition.
What about your current medications? I saw from Dr. Wassener's records that Claritin and Flonase are your only 2 medications you're currently taking. Is that accurate, or are you taking additional medications?
That's accurate. I'm just taking the Flonase as needed and Claritin as well, just as needed.
Is it fair to say you haven't had any ketamine or narcotic medication since you were discharged from Johns Hopkins All Children's Hospital in January of 2017?
Yes, I haven't.
You haven't?
I have not, yeah.
Any other doctors that you're seeing outside of Dr. Wassener or a primary care doctor that works with Dr. Wassener?
I don't think so, no.
Are you seeing a doctor that specializes in pain or CRPS currently?
No.
Do you know the last time you met with a physician who was a pain doctor?
I can't tell you. Sorry, no.
Have you had any flare-ups of your RSD or CRPS in, let's say, 2018?
I don't think I did, no.
What about 2019?
No.
Dr. Kirkpatrick also provided a view of Maya's future needs, as evidenced here.
So your interpretation of Dr. Bifocal's report is he said that it's medically necessary for Maya to have somebody taking care of her 24/7 from an agency hire, correct?
He gave 2 options, one for private hire and one for agency hire, and it indicates that it was recommended by Dr. Kirkpatrick.
It was Kirkpatrick recommending that Maya was going to need somebody with her 24/7 to take care of her starting at age 18 for 10 years. True?
Again, I don't know if it necessarily needs to start at age 18.
Well, your calculations have $5,297,715 in ketamine. Did I get that right?
Yes, that's the high end range of the worst case scenario.
And those numbers also came ultimately from Dr. Kirkpatrick, right?
Let me see. Yes. It indicates in Dr. Bifocal's report that Dr. Kirkpatrick recommended those, but I will defer to the medical testimony in Dr. Bifocal's.
Right. And I promise you, I'm trying to be fair to you. Again, you're just running the numbers. You're not saying that this is medically necessary, but the numbers provided to you calculated of all of these damages up to almost $5.3 million in ketamine, which would envision Maya starting ketamine immediately and going until she's 80. True?
It's calculated over her life expectancy of 63.6 years. it's an average of, he indicated 5 sessions per year at $12,000 per session, so that's $60,000 a year.
It is unclear how Doctors Kirkpatrick and Hanna explain Maya apparently leading a normal life, given their views about ketamine and CRPS. However, whatever the reason, it is very positive to see that she is seemingly doing so well, as evidenced by her public social media profiles. So, I've now covered the timeline, up until Maya's admission to Johns Hopkins All Children's Hospital. In October 2016, I've given an overview of CRPS, of somatic symptom disorders, of ketamine, and of medical child abuse and Munchausen by proxy. I've provided information about Doctors Kirkpatrick, Cantu, Hanna, and Chopra. I've also shown Dr. Kirkpatrick's assessment of Maya, as well as his assessments of Hanna and Elizabeth, and telling Jessica's story. The last part is a look at the trial, and what was some of the arguments outside the presence of the jury.
We have evidence in the notes, the personal notes that Mr. Kowalski authenticated on the stand where Mrs. Kowalski wrote she was giving IV ketamine at home through the court. We intend to admit that record. We have the doctor that will come and testify either by video or live to these notes. We also have evidence in Dr. Hanna's records that he had Mrs. Kowalski sign a contract to not put ketamine IV through the port. So these are absolutely, this is not a one-off. This is part of the theme that is part of the defense's theme. They were certainly welcome to call this witness across.
Who is going to testify that there was actually ketamine infusions at home? Who is going to testify?
Dr. Brandon Alexander.
Okay. And
who?
Dr. Brandon Alexander is the resident I'm referring to, Arnold Palmer, who had this one interaction and put this down in his record. He has no basis.
As a general statement, the question of ketamine infusion at home has been something that's been percolating for years, and every single time I try to get actual direct testimony, it always seems to be a hearsay basis for this. So unless and until there's actually someone that comes and testifies, I am thinking I've got a 403 issue.
This is a doctor who was a resident at the time and took the history from Mrs. Kowalski that she was giving ketamine at home. And so I think the concern was...
This was done in the ER room, the ICU?
No, this was an admission. Is it an admission? ICU admission. At Arnold Palmer. It says, mother states that she has been doing ketamine injections through the patient's port at home of 50 milligrams up to 30 minutes PRN. Mother states the patient will occasionally go days without needing ketamine, but sometimes she needs it multiple times a day. That's what I relate to be by the mother. The witness says on line 3, the way I documented this means that when we were speaking, we talked about getting the ketamine boosters every few weeks, as she does with Dr. Hanna. However, I stated that she's been doing ketamine injections through the patient's port at home. And if you read on, I documented several things. I said ketamine injections, which means IV. I stated through the port, which means I was told through the port, and I say at home. So he reiterates that the mom was talking at home. There's no question, Judge, but that this is a party admission, if not medical history, and it is a statement that the doctor's testifying he was specifically told by Mrs. Kowalski, which he then documented in the medical record as mother states. So I'm not sure what the objection is.
The objection is relevance, 403, and along the lines of what was discussed on Friday afternoon and this morning. This is a resident, and it all went to the Chapter 39 issues. This is a resident who's not competent to give these opinions. His record also indicates that Maya had a normal gait during this admission at Arnold Palmer Hospital, so his records are completely unreliable. The prescriptions at the time were for IV ketamine at home. So it's confusion on the resident's part. The court on other occasions has refused to admit evidence that would be along the same lines as this. Those are our objections, Your Honor.
He also works for Johns Hopkins.
Oh, he now works for Johns Hopkins, by the way.
At the time.
And he joined them in 2017 and worked for them during this deposition.
There's already testimony that for the Kowalski family, both Jack and Maya, if I remember correctly, that she was receiving ketamine at home orally.
Correct, but they specifically denied that there was any injections of ketamine done at home.
Just out of curiosity, though, other than, how is this not a collateral issue? Well, y'all love that stapler, don't you?
I'm sorry, it's not a microphone.
Yeah,
my apologies.
It's not collateral, Judge. It goes, again, to the jury's assessment of Mrs. Kowalski's state of mind. It goes to the Munchausen's concerns that are being raised, its support of that. They're putting this issue in front of this jury, and the jury, I think, needs to understand, as part of their assessment of this case, what types of decisions were these parents making. And at this point, there's evidence that Mrs. Kowalski was, contrary to the testimony that's been presented to this jury, was in fact injecting ketamine into Maya.
But in fact, this goes right to the heart of the defense. For us to be able to say to this jury, we had concerns, they weren't turning over records, we had concerns with over the safety, and in fact, on both real-time and retrospective review, we're right. This is, respectfully, an extremely dangerous practice for a mother who's an infusion nurse with access to these supplies and access to ketamine and knowledge of how to access a port to be able to infuse an anesthetic on her daughter through the port. Now, if they want to cross-examine and say, you know, what other evidence you have, it's not just this record. This is not an outlier. In this exact same time period, we have the admission through the note from Mr. Kowalski, who turned over his wife's diary that says she gave ketamine through a port. And we have Dr. Hanna 2 days after that record having Mrs. Kowalski sign a contract. So as the Kowalskis inject these themes into the case, these are parents' rights. They get to do, you don't have a right to second guess it. This goes right to the defense of our case to be able to explain that there were things that raised red flags, including the refusal to give outside records, which show exactly.
I still am concerned about the 403 issue in this particular case. And knowing for years this concept of she being Beata Kowalski used ketamine in her suicide, and the reality is Maya and Jack Kowalski already testified that she had ketamine at home orally, and I'm not seeing the huge prejudice here that you seem to be suggesting, that if we don't show that it was done via an infusion versus orally, that somehow makes or breaks the case. I feel like I give 1 inch and then 4 or 5 feet later I'm trying to rein everybody in. And so that's my concern, that given the history of this particular issue, and I know, Ms. Krause, you weren't part of the 2 years that I was dealing with this particular issue, I am really concerned that if I give 1 inch here, this is going to turn into something completely different.
We're not going to start trying to say, and that means she used ketamine to kill herself. We've already stipulated that she committed suicide. We didn't even want anything in about the records about the suicide. Plaintiff's the one that put all that in. We were willing to say she committed suicide. They're the ones that wanted to put in all the records about it, and put in the picture of with the IV in her arm. They're the ones who put all that in.
I still maintain this is a 403 problem, and I'm going to exclude it.
Judge, can we make one last record? And I promise I'll sit down. I know it's very frustrating to the court, but again, as Mr. Hunter noted, they made 5 references in opening statement that we have no basis to suspect Munchausen, no basis to take the child away, despite the court telling them not to do this. These records go right to the heart of a healthcare provider's concern. Ketamine through an IV can be lethal if not properly managed. This is not about oral ketamine being taken with Gatorade that can cause some nausea and vomiting. This is exactly what our experts are going to come into this court and testify that there is a valid concern for this. They have made their entire case about there was no valid concern for Munchausen's. You had no right to put it on the transfer codes. You had no right to blame these poor parents. This is among the 3 biggest pieces of evidence for the defense to be able to turn to this jury and say, we have the records that we can line up that show a mom told a doctor as an admission against interest she was giving IV ketamine through a port. We have our own handwriting that says she was giving IV ketamine through a port. And 3 days after her own handwriting, Dr. Hanna makes her sign a contract. And to cut the defense off from being able to say that gives the plaintiff this unfettered license to have told this jury over 3 weeks that All Children's has no basis to accuse Munchausen, to suspect Munchausen. This is the evidence of it.
I continue to remind, we are not trying the Chapter 39 case. And as much as the last few days I feel like that's what the defense wants me to do, is to try the Chapter 39 case, I continue to believe that the 403 problem with respect to this evidence vastly outweighs whatever probative value it has for the defense. It's not coming in. I'm about ready to just say nothing comes in, honestly, because everyone's arguing so much about this, which further makes it clear to me that the purpose of this is not is different. The purpose of, let me just say this. I remain very concerned about the 403 issue. That is huge, and I know that's right out there. What's next?
The next set of clips show discussions outside the presence of the jury related to Munchausen by proxy.
The hospital's position on this, from the defense's point, is very clear. The diagnosis of CRPS is questionable. Whether she has it or not is subject to debate because there's no test to rule it in. There's no test to rule it out. It's a syndrome. It's not like you can take a blood test and say that you have CRPS the way you could say you have leukemia. But from the All Children's point of view, whether she had CRPS, whether she had psychosomatic pain, conversion disorder, or whatever the new language was that you heard from the doctor, the medical treatment for this is the same. Cognitive behavioral therapy, physical therapy, occupational therapy, all of which we provided, and all of which, to the extent we could not provide, we were trying to transfer to other institutions that had a higher level of care for this.
Well, then my question back is, does it matter whether mom had Munchausen? Because one, Johns Hopkins All Children's Hospital has taken the position that it's a children's hospital, it's not an adult hospital. It did not seek to provide any care and treatment. There's certainly evidence that's been adduced that this is a diagnosis that would impact Viata. Frankly, I'm struggling to see how it goes to what type of care for CRPS that the hospital did or did not provide to Maya, and the focus is on Maya for medical malpractice. So that, I'm struggling with why we're spending so much time on it when it doesn't seem to be an actual issue.
With respect to Munchausen by proxy, I think the court a second ago spotted the issue, which is that's a diagnosis of the mom. So they take a position that's duplicitous. That is in their records, Munchausen by proxy, there's no question. But then they retreat and say, well, we're a pediatric hospital, we can't treat or diagnose adults. But yet their records of Maya Kowalski are littered with an adult diagnosis. And then to take the position that the treatments for all of these conditions are identical, well, that's preposterous.
Please, the court, I'll take these in order if you wish. The first thing I heard was a question of our position with respect to the question of whether there is CRPS here. I'll address that first. Our position is and has been that Maya Kowalski does not have CRPS, that she has a psychogenic disorder of some sort, and that is what we suspected at the time of hospitalization. And that is what we had charted throughout the hospitalization. Throughout the hospitalization, however, we never ruled out CRPS. It cannot be definitively ruled out. The point here is that this patient had a pain syndrome of some sort, and whether it was CRPS or whether she was a victim of Munchausen by proxy and or had conversion disorder or some other psychogenic pain syndrome, the point remains that the treatment for those conditions is the same. And preventing us at this point from proving up, as we intend to do today and tomorrow, that Munchausen's was a reasonable suspicion, if not the correct diagnosis, goes to the heart of the defense.
But the diagnosis goes to mom and not to Maya.
That is correct, Your Honor, but it's material to Maya for this reason. Munchausen by proxy may well be, and probably is, an adult diagnosis. It's a diagnosis of the perpetrator. But we have to treat the victim. Maya has Munchausen by proxy. The point is that she's a victim of Munchausen by proxy and or a conversion disorder that is associated with it. That was what was thought at the time. That is what we think today. The question of whether there is a diagnosis of Maya personally, her individually, with Munchausen by proxy is a red herring. The point is that syndrome, we believe there was reasonable cause to suspect and conclude existed, and that it was influencing what was happening and being exhibited in behavior by Maya. That's the point. The central point here, the overarching allegations, as I understand them to be, and as the defense has developed its case, are essentially twofold. Number one, there is an allegation that we failed to appreciate and honor, if you will, a diagnosis of CRPS that this patient had received from essentially 2, if not 3, outpatient physicians. We were alleged to have been negligent in not recognizing that diagnosis, accepting that diagnosis, and continuing the care of that diagnosis as had been outlined by Drs. Kirkpatrick, Cantu, and Hanna, which that we believed to have been destructive and dangerous. But the allegation is that we failed to proceed with treating her in accordance with that diagnosis and that treatment plan. The secondary allegation is that instead of doing that, we suspected a psychogenic component to her presentation. We suspected a psychogenic component to the way in which she was presenting her pain syndrome, as did, by our count, approximately 40 other physicians at 2 other institutions, at Lurie Children's and Tampa General, that we suspected that there was Munchausen's by proxy and or conversion disorder and or factitious disorder, depending upon which of those you subscribe to, and there's a good deal of controversy about them that Your Honor is about to hear a good bit more about. But the point is that the soul of their allegation against us is that we suspected the psychogenic constellation of presentation symptoms, and that was a deviation from the standard of care in the way we pursued that and allegedly failed to properly treat it.
Let me attempt to articulate some thoughts I had that I've been spending over the weekend trying to coalesce into something hopefully articulable. Assume for the sake of argument, mom had Munchausen or whatever of those terms you wish to apply. So just assume that to be true. Does that change anything with respect to how the hospital should be treating its patient, who is not the mom, but Maya? At what point do we need to keep going on and on and on and trying to prove mom has Munchausen, because even if that's true, how does that change what was done or not done to Maya in this case? So if you'd like to comment on my rumblings there, I'll give you a chance. Because ultimately I need to make decisions on admission of evidence.
I understand, Judge, and I'm kind of flabbergasted. Let me start by noting that based upon Your Honor's rulings, this is not just a medical malpractice case. A lot of it is a medical malpractice case, no question. But it's a battery case, it's a false imprisonment case, it's a negligent infliction of emotional distress case, it's an intentional infliction of emotional distress case. Over and over and over again, we have heard from the plaintiffs this evidence sponsored, that evidence admitted on the basis that it went to the plaintiff's or the decedent's state of mind. The decedent's state of mind is what caused, allegedly, her to commit suicide. The allegation against us is that we created her state of mind. And we created her state of mind by doing as was suggested in opening, and that is that we were suggesting that her actions and her approach to her child's disease was harming the child. We are accused of separating the child from the mother. Why? Because of the allegation that the mother was doing harm to her child. That allegation is based around Munchausen by proxy. The defense of this case, with all respect, Your Honor, whether it's malpractice, whether it's false imprisonment, whether it's any of these things, all of the defense of this case rests upon the proposition that the pattern and practice of therapeutic and maternal behavior here was dangerous and inappropriate to this child. And that is why reports were made. And that is why suspicions were hatched. And that is why we attempted to act as we did with respect to the discharge of the child or the lack thereof, and the circumstances under which we attempted to treat her and to transfer her elsewhere for more treatment in accordance with the standard of care. But we cannot defend our case, Your Honor, without the idea being a centerpiece that it was reasonable for us to suspect that there was a Munchausen by proxy or a factitious disorder by proxy going on here, and that we were reasonable in suspecting that, and that we were reasonable in acting upon that as we did, and attempting to treat this patient as we did. That is central to the defense of the case. If you emasculate that, you've emasculated our defense.
This concludes the video. I hope that I have succeeded in offering a different perspective on the case and trial. More importantly, I hope to have delivered a useful summary of functional neurological disorders, CRPS, and medical child abuse. My sincere hope, though, is that this discussion will encourage further dialogue regarding the use of ketamine. While I believe it has its appropriate applications, it is not a universal solution. When a patient's issues persist, reoccur, or worsen, it should not automatically lead to escalating dosages. Instead, those administering ketamine should reconsider their diagnosis and recognize that healthcare professionals with diverse training and experience may be better suited to assist the patient. Doing research for the video and coming across the stories of Hanna, Jessica, Fallon, Andrea, and others deeply concerns me. Regarding the trial and verdict, the myth that CRPS causes the worst pain known to man is now in court documents. Ketamine has been given free promotion, and doctors giving evidence have perpetuated the notion that psychological treatments are to be avoided. I also understand that some hospitals are now hesitating to shelter children in suspected abuse situations due to concerns about potential financial repercussions. Additionally, mandatory reporters are reconsidering their roles, which is perhaps understandable given the intense negative comments expressed during the trial, both in the courtroom and beyond, directed at those in the caregiving profession, including online abuse for supporting the hospital and even death threats. The trial created divisions, animosity, and in some cases it brought out the worst in people. Maybe this video will help find a balance, or maybe no one will watch it. But doing it satisfied a need in me to say something, and job done.